Good morning and welcome to one more topic of hematology. And you can say basically this one is not the last, but like second last topic for hematology. And again, I would like to start with my story, which I told you in the start. Um, I told you whenever like someone is presenting and you notice that the RBCs are decreased, so uh, what to do next. And in that one I mentioned like you have to see all the other cell lines, like either it's only the RBCs which are affected, or either all the other cell lines are those which are affected. So when all the cell lines are affected, so uh, we call it as pan, means all, cyto, cells, and penia, less, so simply all the cell lines are decreased. Okay. Pancytopenia is the term which is used to describe when there is low RBCs as well as low WBCs and low platelets. Okay, so simply all the RBCs, WBCs, and the platelets are decreased in circulation, and whenever, of course, like someone have all the cells lines are decreased, so we call this condition as pancytopenia, and there are a number of reasons behind that thing. The list is very, very, very long. Okay, so simply anyone whose RBCs or who have anemia or whose RBCs are less than 13.5 gram per deciliter in males, or 12 gram per deciliter, less than 12 gram per deciliter in female, that will be considered as anemia. Anyone whose WBCs are less than 4,000 cells per millimeter of cube, that will be considered as low WBC count. And anyone in which the platelets are less than 150,000 cells per millimeter of cube, that will be considered as thrombocytopenia. In other words, you can also say that pancytopenia is anemia with leukopenia with thrombocytopenia. Okay, so pancytopenia is anemia with leukopenia with thrombocytopenia. Now there is a lot of causes which can cause pancytopenia, and of course, like written in the books, but of course, here I'm not going to mention all, rather the important one. So one thing is called as aplastic anemia. Okay, so whenever you have a blood report in which like the person have decreased cell line of all the cell lines are decreased, so think about aplastic anemia. Now aplastic anemia is basically um, caused by multiple reasons. For example, it could be autoimmune destruction of the bone marrow. It could be as a side effect of certain drugs. It could be after viral infections, that all the cell lines, they go and they are decreased. So there are many causes of aplastic anemia itself. For example, if there is something which is infiltrating uh, uh, the bone marrow, or bone marrow infiltration. For example, the tumor. Like if there is a tumor which have infiltrated the bone marrow, so of course when the bone marrow is filled up with the tumor, so what will happen, of course, uh, the bone marrow cannot function properly, and it will result into pancytopenia. One of the condition is hypersplenism. Now, because this hypersplenism is coming now quite a number of times, so I think like I must talk a little about that one. Okay, because I don't know, like many of you have this question in mind, like what is there. So uh, what is hypersplenism? It's simply um, you know uh, what is the function of spleen? Simply, uh, the spleen function is it's a part of, you can say, reticuloendothelial system, right? So uh, spleen is the area, which destroy the red blood cells, right? So what happens in sometimes, like there is splenomegaly, okay, of course, like due to some reason. So what happens in these patients is like the spleen, it is going to destroy more and more and more cells, okay, which usually like the spleen should not destroy. So due to destruction of these cells, again, like over a long period of time, the patients can present with splenomegaly. The spleen can get enlarged, okay. So of course, like, and they have the reduction in the cell numbers, okay, no matter it is platelets, it is WBCs, it is RBCs. So these things can be present, right? So um, now, other than this hypersplenism, there are other causes of pancytopenias also there. For example, there could be decrease in all the cell lines in megaloblastic anemia, okay, as well as in sepsis. Sepsis is, when there is blood, whenever the infection is widespread. And for example, it could be some condition, rheumatological condition, systemic uh, erythematous, systemic lupus erythematosus, erythematosus. Okay, so what is systemic lupus erythematosus? Like, it is the short form is SLE. It's again, like, you are going to study this condition in detail in um, rheumatology, but it is a multi-system condition in which, like, what happens is there is what you can say, autoimmune destruction of the cells, you can say. So that's why these patients can present with uh, autoimmune pancytopenia. Now again, as I told you guys, these are not the only causes of pancytopenia. There are many others. Okay, for example, many of the hematological malignancies, they present with pancytopenia as well. But many of them, of course, like the WBCs are raised, but there is anemia with decreased platelet counts, and the WBCs, even if they are raised, like, they are not working normally, so they will be having repeated infections. Copper deficiency can lead to, viral infections can lead to, but viral infections, of course, they will lead to aplastic anemia. So that's a more or less. By the way, there are many parasitic conditions as well which can lead to pancytopenia. For example, a condition called as leishmaniasis. The chances are not so high, but of course it can lead to. So that's why I am including in this one. So these are the causes of pancytopenia. Okay. So other than pancytopenia, what we are going to discuss in this lecture is about uh, erythros, uh, erythrocyte, which is the red blood cells, sedimentation rate, which is also called as ESR. Okay, so now, by the way, I always talk about Guyton, I always talk about physiology. This is one of the few early things which they teach us in medical school when they teach us in physiology. Like, they let us do the experiments of ESR as well. So again, to show you what is ESR, I must take the help from the Bing, and I will write over here ESR. Uh, now, to show you what is erythrocyte sedimentation rate, or ESR, see, what they do, uh, not a rocket science, rather a very, very, very simple thing, is sorry, I don't know what's wrong with my internet, like my computer, for the last 2 or 3 days, but there is something wrong. Okay, I see this one. They put blood in this capillary tube, right? And after 1 hour under room temperature, what they found, like, the blood was like this, like the plasma. The basically what happened like is the RBC settled down, okay, and see there is a white portion above that. So this is how we measure. Like this is a very 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 simple way to measure ESR. Take the blood, put it in a tube. After 1 hour, see how much our RBCs are sedimented or settled down. Okay, so very you can say a common type of way of measuring ESR. So now, what is ESR? The erythrocyte sedimentation rate measures simply it measures you can say how rapidly the red blood cells form sediment when a column of blood is kept upright for 1 hour. So like that's why I show you that photograph, because that show ESR completely. So of course now if you can see again the same diagram, what I wanted to show you is uh, see this one, sorry, see the same one, this one. Now what happened, like if someone have this much column, like this RBCs are settled down to this much extent, so his ESR will be this much, okay, this reading. And if someone for example so see sedimentation rate is equal to 2.6 millimeter per hour. So in 1 hour 2.6 millimeter decrease in the column of RBCs. But if someone, for example, the RBCs settle down more up till here, so his sedimentation rate will be 5 millimeter per hour, right? So makes sense, like very 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 easy thing, like there is no rocket science in this one. Again one more, see they take the they put the blood in test tubes. So you can see over here this one have the highest sedimentation rate, because see that it settled down too much, okay. So like this one, or you can see even this one, okay. They put the blood in this tubes, and after 1 hour they will see how much what you can say the RBC settle down. So now uh, the important thing, uh, what is ESR, why we measure that? Remember, it's a non-specific marker of disease, right? And why we measure that? That in inflammatory processes, like whenever there is any inflammation going on in the body, there is more and more formation of proteins in the blood, or which we call as plasma protein. So there will be, you can say, in inflammatory processes, okay, inflammatory processes. What happened? Uh, there is raised uh, level of plasma proteins, right? So now, because there is raised level of plasma proteins, what happens that due to these plasma proteins, the RBCs, they you can say they form more clumps, okay, or more clumping is there. So this clumping formation is called as this process, or this clumping is called as basically Rolex, REAUX, okay, Rolex. So you can see over here, for example, maybe we can found, sorry, okay. So what happens is, you can see this diagram. So these are the erythrocytes, and see they are dispersed. So when we allow them to settle, like to stand still, they will make this clumps, or they will sit on each other. And now, if there is more plasma proteins, they will more stick together. If there will be less plasma proteins, they will stick together less, right? So now You can see over here. Again, this diagram shows the same thing. You can say over here, this is the clumping formation. So before, like, it was like this, but after 1 hour it was like this, because there is all the RBCs, they form a lot of clumps, right? So this is called as Rolex formation. So uh, now when these clumps of cells sink uh, down, of course, like what happens, like the column of the RBCs will get down, or and the ESR will be high. Okay, so simply the clumps, you can say, they sink easily than the single cell, and when they are going to sink, it is going to lead to high ESR. So uh, normally, like the ESR, or erythrocyte separation rate, normally rises with increasing age. Okay, so when we age, uh, the old people have generally higher ESR than the younger people. Okay, so that's why uh, one thing, remember, guys, that like the normal ESR levels, okay, in the body uh, is uh, is defined as, what you can say, less than 2 millimeter per hour. Okay, uh, so like, but there is a way of calculating it as well. So the thing is, by the way, I will tell you uh, the normal ESR range again, like from taking from some. Yes, so the normal range is around you can say, okay, now again, this one thing can be different in different books. Okay, 1 to 15 millimeter per hour for males, and you can say 1 to 20 millimeter per hour for females. Okay, uh, so like there is different for males and females. So now this is the normal values, okay, of ESR. Now as we know that, ESR increases with the increasing age. So of course we should be some set, you can say, levels of ESR when to worry about. So generally speaking, it is taken as 35 millimeter per hour. So you can say when it is more than uh, 35 millimeter per hour, so it should be investigated. Okay, more investigated, more like you are going to decide more tests, what could be the patient have. Okay, what could the patient may have. So like that warrants, you can say, some investigation. So okay, more investigation to search for the cause. And what are the causes? Of course we are going to discuss now. Okay, so now um, simply when the ESR is coming back more than 35 millimeter per hour, for example it is 40 millimeter per hour, so you should be like, it should be a suspicious, like you should be suspicious, like there is some disease activity or disease processes going on in that patient. So generally speaking, ESR, or you can say causes of ESR, uh, what is the cause of ESR? Remember, infections is the more important thing. More plasma proteins, more this thing. Then neoplastic conditions, okay, or neoplasms, neoplastic conditions will give increased ESR. One of a very important neoplastic condition which you will study someday is called as multiple myeloma. Okay, so the patients, they may have multiple myeloma as well. Then again, many of the rheumatological conditions, or you can say connective tissue disorders, uh, can lead to more like increased ESR. For example, one of very important condition is called as giant cell arthritis, or it is also called as temporal arthritis. Uh, it can cause blindness, So this thing, or polymyalgia rheumatica, this is one of the conditions which can lead to, and there are many more, many more. Okay. By the way, ESR can be raised in anemias. Makes sense. There is less RBC, so the column will be decreased, as well as it can also be increased in renal diseases. again, this thing makes sense because in renal disease there is what you can say less erythropoietin, less RBCs. Okay, so things like this, and of course, there is a lot of causes of ESR. But how I remember, see, infections, malignancies, and inflammations, uh, all these things are going to raise the ESR. Okay, so uh, uh, what happens, by the way, in inflammations, uh, infections, inflammations? Okay. By the way, infections can cause inflammation, and as well as like these GCA and all this one is a cause of inflammation as well. So in inflammations, there are many other proteins like alpha globulin, like fibrinogen, and all of them they are positively charged. So that's why like ESR is too much raised, uh, and the ESR basically begins to rise around 24 to 48 hours after acute inflammation. But like as the inflammation resolves, it come back to normal slowly. So you can say there is some lag time. Okay, a very important thing. Like there is a lag in increase of ESR and decrease of ESR after in acute inflammation. Okay, so now the important point over here is what see if someone have inflammation today, so maybe his ESR will be raised tomorrow, and if someone inflammation is resolved today, so it's not like this like his ESR is going to come back to normal today. It's not like this. There is some lag time. Okay, sometimes it takes around months or weeks to come back to normal. So this is very 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 important thing. Okay, uh, now uh, we use this ESR a lot in medicine. Why? Because simply, nowadays, by the way, we go for CRP, that is C-reactive protein. When the time will come during these lectures, I will talk about CRP as well. ESR is very useful in in diagnostics. Okay, so I told you temporal arteritis or GCA, giant cell arteritis, they are the name of the same things, or polymyalgia rheumatica, or multiple myeloma, or any other of connective tissue diseases, or rheumatological conditions like SLE or rheumatoid arthritis. Uh, the ESR is highly, highly, highly raised. Okay, so that's why we use ESR in diagnosis. By the way, uh, if you're suspecting someone have temporal arteritis or giant cell arteritis, this is the first investigation we do. And if the ESR is come back as high, like really high, so it's a diagnostic of that conditions. So that is very important. So ESR we can use for diagnosis of different conditions as well. Sometimes ESR can be used to monitor the response to the treatment we are giving to the patient. Okay, for example, again in the same condition, giant cell arteritis or temporal arteritis, when we put these patients on corticosteroids. So when we put these patients on corticosteroids, we keep on doing ESR just to see either it is coming back as normal or not. Okay, so this thing is very 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 important, right? So now CRP, C-reactive protein, we are going to talk about that thing um, in the coming days. Okay, so the third part of this lecture is blood film abnormalities. Okay, now what is blood film abnormalities? If you know what the pathologists do, uh, for example, if someone have malaria, what we do, we take his blood, we see our blood under the microscope, we see if there is any parasites uh, in that, merozytes and all this stuff. So the important part over here is what? Simply, uh, whenever, okay, we say it is, we write as a blood report like do a peripheral film. So now what is peripheral film? Simply they put blood on the slide, and they see it under the microscope. They see like how the cells look like. So uh, we 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 ask for this thing, okay? So of course, like the peripheral blood film is like provide too much help in diagnosis um, in many clinical scenarios. For example, um, when they correctly identify various cell types, of course, like the pathologists, they have like the great knowledge of identifying this thing. Uh, so, of course, like they point towards certain conditions. So, see, whenever they see the blood under the microscope, they check like how the RBCs look like, or you can say they see the shape, they see the color. If you know, we say for example microcytic hypochromic anemia. Okay, so it means like microcytic, the cells are smaller in size. Hypochromic means what the color is not reddish, rather it is hypochromia, decreased discoloration is there. For example, when we say uh, spherocytosis. So what it means, like the RBCs are sphere shaped, or when we say, for example, cell, sickle cell disease, or we say leptocytosis. So of course, like we are talking about the shapes of the cell, right? So uh, now I would like to put some photograph, and whatever is not available, of course I'm going to show you online. Okay, that's what I always do. So sorry for this inconvenience. Wait, uh, okay, uh, I had to make this one. So you can see over here, um, I can enlarge this photograph too for you guys. Okay, and you can see the abnormal morphologies which are present, of course, plus uh, so now you can see over here, microcytic means small cell, right? This is the normal, this is microcytic. Uh, and you know, like it is biconcave shape, so it is a little lighter in the middle. That's the normal thing. So see the causes they have written: pyridoxine deficiency, thalassemia, iron deficiency anemia, chronic disease anemia, sideroblastic anemia, right? And then there is macrocytic, see the normal cell and see the cell is bigger in size. And we have discussed this thing. Vitamin B12 or folate deficiency, liver disease, myelodysplastic syndromes, as well as chemotherapy. So, small cells are called as microcytic, large cells are called as macrocytic. Pale cells are called as hypochromic, right? Um, then you can see um, spur cells. See, you will find the spurs over that. They are also called as acanthocyte, right? So now, when the spur cells are present or acanthocytes are present, these are spiky cells or spiky appearing cells. They are present in A beta lipoproteinemia, as well as liver disease, as well as you can say they can be present in McLeod blood group phenotype. Okay, leave this thing. Post planectomy, they can be present. Okay, um, Burr cells or echinocytes. Okay, or echinocytes. So uh, now, how to differentiate between these two? Remember that Burr cells are less spiky. In acanthocytes, the spikes are more. So they are also called as echinocytes, right? The Burr cells are also called as acanthocytes. So it can be present in uremia, liver disease, as well as post-splenectomy. We can see these cells as well. Now you can see over here schizocyte. So what is schizocyte? See, this is a schizoid looking cell. Then there could be bite cell. What is bite cell? See, looks like the cells are bitten. So this one occur in G6PD deficiency and unstable hemoglobin disorders, as well as oxidative drugs. Then elliptocytes, the cells look like ellipse, so hereditary elliptocytosis. Spherocyte, hereditary spherocytosis. A stomacyte, like, see, they look like this one. So uh, simply, why they are called a stoma? See, you can see the mouth. Stoma is mouth, right? So see, cells with mouth shape area of pallor. So again, they can present in hereditary stomatocytosis or liver disease. So we can also see uh, target cells. Target cells, see, they appear like a target. Okay, target, like, see, yeah. Do you know the dart game? So they look like a target. So they can present in thalassemia, hemoglobinopathies, postplanectomy, liver disease, and you can see the sickle cell shaped cells, sickle cell disease or sickle cell disease. They can be present. Then there could be teardrop cells. They appear like tear. They can be present in myelofibrosis. Then there is hemoglobin C crystals, which is present in hemoglobin C disease. And then there could be red cell agglutinate in different hemolytic anemias. I told you, read about Coombs test, and then you would well understand this thing. Um, as well as Rolex formation, which we have done right now. Okay, see, RBCs sit on each other. So chronic liver disease, malignant lymphoma, multiple myeloma, as well as chronic inflammatory disease. All this one can lead to this thing. So okay, uh, of course, like there could be pencil shaped cells as well, which occurs in iron deficiency anemia. There could be uh, what you can say. There could be fragmented cells as well. Okay, so of course, like, which occurs in uh, microangiopathic MAHA, microangiopathic hemolytic anemia. Okay. Other than this, like, guys, there are few terms which I'm sure, like, maybe you guys know before, because they are so common and they are so basic. Uh, we study them in start. You will find this term in the books: POI, kilo, uh, cytosis. So what is poikilocytosis? It is simply um, abnormal shaped shapes of RBCs. Okay, we call as poikilocytosis. Uh, okay, when thing is called as anisochromia. So remember, it is something related with color. So it occurs like when there is different shades of color in RBCs. Okay, so now both of them, they are present in uh, iron deficiency anemia, right? Like, both these are features of iron deficiency anemia. So guys, again, like, I will show you some of the things over here. Wait. Okay. So there is something called as Heinz bodies. Okay. Uh, okay. Yes. Heinz bodies. See, yes, this one. So you can see over here Heinz bodies, right here. So what you can see, these are the bite cells they are showing here. So just see this one. You can see these blue dots, right? So Heinz bodies are basically unstable like, they appear in unstable hemoglobin state. So, like, these are basically collection of the hemoglobin inside the cell. Okay, these are called as what? Heinz bodies. Heinz, Heinz bodies. Then there is something called as Howell Jolly bodies. So yes, this one is better one. Howell Jolly bodies. You can see over here. When someone have people have a splenectomy, so there is no spleen, then we see like such a type of bodies. Or when the someone's spleen is not working. Okay, so they are called as Howell Jolly bodies. Um, you can see over here, yeah, near. See, this one is Howell Jolly bodies, right? So this thing. Then there is something called as there are many things. Okay, I'm just showing you the common things. Okay, okay. Then there is something called as Pappenheimer bodies. They are more or less, you can say, the same thing like Heinz bodies or whole jelly bodies, and they occur in post-splenectomy patients. A very important thing, which was important before, but nowadays not so important. That is something called as, you can see here, very good diagram of this one. Okay, you can see over here. See, do you know what is eosinophilic staining and what is basophilic staining? So see, you can say there is stippling of basophils. Basophilic stippling is there. This is called as what? Basophilic stippling. Okay, I will show you this one. See, basophilic stippling of the erythrocyte. So see, small dots of staining is there. So this basophilic stippling is present in lead poisoning, in thalassemia, in myelodysplasia. Okay, so this is called as basophilic stippling. Then there could be, okay, not so important, but again, like because we are studying this thing. Yes, this one is a nice one. You can see a ring type of structure, right? These are called as Cabot rings, Cabot, Cabot rings. These are called as what? Cabot rings. So you can see over here, Cabot ring. This one again, they occur in myelodysplasia as well as megaloblastic anemia. Okay, same thing like that. I want to show you um, abnormalities in RBCs as well, WBCs as well. For example, um, I was talking about, if you remember, um, megaloblastic anemia. I told you about, like, there are some megaloblastic changes. So what are megaloblastic changes? You can say that when we see their neutrophils, okay, see, this is the normal neutrophil, and see this one, there is too many segments are there. Okay, see, too many segments are there. So this is called as hyper segmented neutrophils. So what are the condition when hyper segment neutrophils are there? Simply it is it shows, like, that there is abnormality in the DNA synthesis, and it occurs in vitamin B12 deficiency. These are also called as megaloblastic changes. And what are megaloblastic changes? Simply which in which, like, there is hypersegmented neutrophils. Okay, so uh, this one occurs in megaloblastic anemia. Other than that, I can show you. So this is like, believe me, whatever I'm telling you, like this one, hypersegmented neutrophils is important to remember. You can see over here, see how many segments of neutrophils are there in this one. So this is called as hypersegmented neutrophils. Then there is something called as yeah, by the way, one photograph we see over here, I see over here, this is, you can see over here, uh, this is a neutrophil, and the nucleus is fine, but see, a small dots are present, right? So this is like toxic granulation. This one occurs in, like, when you found this thing in the neutrophils, it occurs in bacterial infections or after burns or after poisoning. You know, these things are present. And then there is something called as oil rods. So uh, now uh, this wait, yes, you can see, no, wait, I will show you first. Yes, this one is a good one. You can see that uh, there is this rod or this rod, right? You can see this rod, right? So or yeah, this one. See, you can see a rod over here, right? This is called as oil rod. So you can see over here. See, yes, this one is a very nice one, but like this one is a drawing, not the original one. So you can see over here these rods. Okay. Now this one is present in acute myeloid leukemia, AML, acute myeloid leukemia. Okay, so you see, like, they're showing a myeloblast with eye rods. So myeloblast means what? Are immature cells, right? Um, the last one, not so important, but that is called as smear cell. I must show you that thing as well. I show you this cell for um, okay, smear cell, smear cell. Okay, you can see like they look like this, that it's actually, I'm not finding a good one, diagram for that one. Basically smear cells, uh, but this one is being like, maybe you can google, you can find a good one. uh, Smear cells are basically uh, found in CLL, or chronic lymphocytic leukemia, right? So, but of course, like I couldn't found a better diagram for that. So anyhow, uh, okay. So what we were discussing is the abnormal shape of RBCs as well as the abnormal shape of WBCs, right? So uh, now, what you can say, there is a term which is used in diagnostics, you can say, that is called as leukoerythroblastic blood film. Okay. Now, to understand this thing, leukoerythroblastic blood film, remember what is blast cells. Blast cells are basically immature cells. Okay, when we see immature cells in the circulation, we call it as blast cells. So that's why they write myeloblast. So blast means immature cell. So see what the name shows. This is a term which is used to describe, you can say, used to describe the overall appearance of a blood film. Okay, so what happens is, uh, what is this picture? There is immature RBCs, RMCs, so RBCs and WBCs, right? So when we see that in the film, that film, that there is a lot of immature WBCs and RBCs, they call it as leukoerythroblastic blood film, right? So now, what is the causes of this leukoerythroblastic blood film, like in which, of course, the immature cells are now present in the circulation? So again, bone marrow infiltration. Again, what I always give the example of tumor. So, for example, when there is tumor which is invading the bone marrow, of course, the immature cells will start appearing in the blood. Okay, because they will no more be staying in the bone marrow. So this thing, it occur in severe sepsis as well as hemolysis. There could be leukoerythroblastic film, or one more thing, but like that is called as idiopathic myelo fibrosis. So when there is fibrosis of the bone marrow, this kind of condition can be present as well. So, guys, that's all for now. And uh, what we are going to do is, we have to cover like few topics of more of hematology, which we are going to do next week. We will do like coagulation profile. We will do um, that's a big topic, by the way. In that one, that's good. I can talk about DIC, disseminated intravascular coagulation, as well. So we will do clotting profile, and then we will move on the biochemistry test, and then we will move on to other type of test, okay, which we can do in the blood. So thank you so much, guys, for listening.